can help your patients in your own practice. We're really excited tonight to spend some time talking about the caries screen meter and its clinical application. Before we get started, I have just a few housekeeping items. First, you are all muted, so we can't hear any comments or questions verbally. Please make sure to type questions into the questions box on the right-hand side of your screen. At the end of the presentation, we'll have about 15 minutes to answer questions. We will do our best to get through as many as possible. Any questions we don't have time for will be addressed by email, and we also offer one-on-one webinars for practices interested in learning more. So with that, I would like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech and the Carifree system. He is the world's leading authority on ATP as it relates to the caries risk assessment. Dr. Kutsch has been successfully practicing dentistry for 35 years, still practicing 3 days a week here in Albany, Oregon. He has a huge vision for curing dental caries, motivating him to start this company. And it continues to motivate him in the research he's leading to improve caries diagnosis and treatment. He has a lot of passion for what he does, and it's always great to hear him speak. So with that, Dr. Kutsch, take it away.
Hey, thank you so much, Janelle. And thank you, everybody, for spending the next hour with us here. And welcome from beautiful downtown Albany, Oregon. I really enjoy doing these webinars, and I have to tell you, this is one of my favorite topics. And so it's kind of fun for me to actually put this presentation together and go back and kind of review and look at all the work that we've done in ATP. And it's fascinating how far that we've come with it. And so I hope that you'll find this interesting, and even more importantly, I hope that you'll be able to apply these principles in your own practice with your patients. One of the things that I've always tried to teach in the last few years is to really learn to understand the patterns that we typically see with dental caries and learn how to identify those patterns, and then that kind of leads you into an easier understanding of, where are we going to go with this patient and how do we help them. The most common usual suspect that we see in our practices today, based on, this is an internal study that we did on 6 private practices. It was a multi-site study that we did for 2 years. Turned out to be, saliva. 63% of the patients, and we have now over 12,000 patients in this study, 63% of them had a salivary issue, and we commonly run into this. It's the medications that everybody, Americans are taking, the multiple medications that Americans are taking is an issue. And of the patients that we screened with the caries risk assessment form, 55% of them had dietary issues. And typically in the dietary issues, we're seeing people that are either eating too much sugar during their day, and of course Americans eat 23 teaspoons of sugar on average per day, and we consume 51 pounds of high fructose corn syrup per person per year here. Or they're eating too frequently, and that tends to be, I think with our lifestyle, we tend to snack and nibble all day rather than, eat distinct or separate meals. But bacteria, and the patients that we tested, using ATP as a metric, 51% of the patients that we tested just across the board that we screened in practices had an elevated bacterial load in their mouth. And of course, one of the things that we've really begun to identify in the last 3 or 4 years is the genetic influence for dental caries. And of course, at the end of the day, we know this is really a disease about pH. It's, a bacterial origin, but it's a disease that results in prolonged periods of low pH in the mouth that, results in net mineral loss from the teeth. So tonight, really, we're going to be focused on this suspect. We're really going to be talking about the bacteria and using ATP as maybe a biometric to help us in our diagnosis and maybe in our therapy as well. So going back and just reviewing some of the research literature on ATP, this is Robisch from 1978, and Robisch actually started and published his paper in 1978, and ATP bioluminescence has been around in industry for over 40 years, and we use it, in about every kind of industry that you can think of to measure, looking for levels of bacteria, particularly on surfaces or in food or in wastewater or what have you. But Robisch in 1978 started to look at, well, does the ATP levels in the plaque in monkeys, did that relate to the total amount of bacteria that were present? And he actually measured ATP, the actual amount of ATP in those days, and compared it to the amount of protein content that was present, specifically from Streptococcus sanguis. In 1979, he followed this up with a paper that looked then at measuring the ATP using bioluminescence technology. So rather than trying to separate and look for the ATP and measure it, it's easy to do with bioluminescence. And really, I guess I didn't have any scientific slide in here to kind of explain the process, but you mix firefly juice, basically luciferin and luciferase with ATP, and it produces light. So if you've got those two reagents in a swab or in a test tube, and you add a sample that has ATP in it, it's going to produce light, and the amount of light that's produced is directly related to how much ATP was present. So we can extrapolate from that, and so that's what we use the ATP bioluminescence for, and that's essentially what we're doing in the mouth. So they followed this with a study and determined that the amount of ATP in the plaque, when measured by bioluminescence, then actually also correlated directly to the total cell mass of bacteria in the plaque of these monkeys as well. In 1983, then, a paper was written in Germany which actually looked at and described in detail the process of using ATP bioluminescence and measuring living cell counts, again, in the mouth, particularly in dental plaque samples, and kind of discuss this entire process and the theories and thoughts behind it. And this was really a paper that I looked at probably 12, 13 years ago and had it interpreted. Actually, it was published in German and got it interpreted into English so I could read it, and really came to understand that cariogenic bacteria in the mouth produce perhaps as 100-fold the amount of ATP that your garden variety bacteria on the teeth are producing that are living more in a neutral environment. And so the first question for me was, well, might that relate to caries risk? Might this be a biometric, not just for us to be able to measure total cell count, but is this something that we could use to replace? At the time I was culturing mutant streptococci and lactobacillus. A few of us in the country were. That still happens, I think, kind of on the global stage in a few practices, but we were culturing, and that's kind of a cumbersome and not exactly high sensitivity and specificity in the levels of the cultures that we were using. But again, it's problematic just from implementation and integrating it into your practice and your schedule kind of routine as well. It became a challenge. So I got a hold of this paper and really read it in detail and thought, well, perhaps this is a metric that we could use to measure somebody's caries risk. And of course, everybody told me that wouldn't work because we were measuring non-specific bacteria. When you take the ATP, you don't just get the ATP of cariogenic bacteria, you get the ATP of all the bacteria that are present in the plaque sample. And so I was told repeatedly by researchers that would not work. And so it was kind of an unexpected result. When we first started studying it, we knew that it was going to correlate to overall bacterial load, but whether or not it would correlate to a person's caries risk specifically was unknown and actually was not anticipated. So that paper, I think, provided a lot of guidance for me. Also, Bill Costerton at Montana State University developed the biofilm models there. Montana State has probably the best biofilm research center in the United States and probably one of the prominent ones in the world. And I had a chance to meet Bill many years ago and was able to communicate with him kind of on a regular basis, and he mentored me quite a bit in those early days as I was looking at ATP bioluminescence, and as it related to measuring it in biofilms as well. One of the things that we know, and this paper comes from 2004, one of the things we know about mutant streptococci, and hence all acid uric bacteria, is that they're able to survive in a very low pH environment because they have four different basic mechanisms that allow them, survival mechanisms there. But one of them that's most important is that they have this ability to pump the hydrogen ion back out of their cell. So as they've got their cell membrane, which is semi-permeable, and you have these acid ions trying to create an equilibrium across the cell, and it's reducing the pH within the cell of the bacteria. The bacteria survives by being able to just pump those hydrogen ions back out. Well, that was from the paper in 1983. Basically, in order to do that, it takes a tremendous amount of ATP. So if there's high levels of ATP present, we could kind of begin to extrapolate. Perhaps these are indicative of two things. It's either you've got a lot of bacteria present, or you've got a lot of bacteria that are in a stress situation that are trying to survive in a low pH environment. So we know that it increases the use of ATP for these bacteria to be able to survive in that environment. What's interesting is that if you follow this continual train of thought here in the research, by 2006 we had identified in the research literature that it's actually the F-type of ATP aces. So these are the enzymes that break down the ATP that provide the energy to the bacteria. If you remember the glycolysis, the Krebs cycle, the ATP breaks down into, ADP and releases energy at that point in time. And that's how all living cells, that's the source of energy for all living cells. It's these ATP aces that actually protect these organisms against being in an acidic environment, and catabolites such as glucose and sucrose were actually found to enhance the protection of these bacteria against lactic acid to pH levels as low as 2.5. So, now we've identified that not only do they produce more ATP, but one of the mechanisms that allows them to do that is a specific S-type of ATP ace or enzyme. There was a study then done in 2012 looking at that there is a different pathogenicity, and of course we've known this for a long time, but there's a different pathogenicity or cariogenicity of different serotypes of strep mutans. And so when they looked at these in this group of Chinese children, this population of children, what they found was that not only was there a difference in the decay levels in these kids, but when they examined the strep mutans that these different strep mutans that these children were carrying, some of them had different activity levels of the F-type ATPase, and actually they identified the gene and then predicted that there was genetic diversity within the strep mutans at this gene level, which allowed it to be more cariogenic or survive in those lower pH environments better than other serotypes of strep mutans, and that perhaps that increases its ability to create decay. If you follow that then on to 2014, now we've actually identified and isolated that gene that it functions to regulate the ATP aces within these bacteria. So, over a span of about 35 years, we went from correlating the amount of ATP present in the plaque on monkeys to looking at actually identifying the gene in the bacteria that use elevated amounts of ATP to survive, and that these are the bacteria that obviously contribute to dental caries. So we've come a long ways in the last 35 years. We actually have identified the specific gene at this point in time, which I think is interesting. Now, this textbook on bioluminescence then was published in 2011, and the first entire chapter on this book, it's all about bioluminescence and its use in biotechnology, is on bioluminescence as it relates to dentistry, relates to the mouth. So this is Kurt Machida and Tom Meyer's work primarily. They're the lead researchers. They're from Oregon Health Sciences University. And this is really a summation of all of the early work that we started with them back in 2006. And then they continued this research on their own. And so if we go look at, this is a great reference, by the way, if you want to learn more about ATP and oral bacteria and kind of the whole science behind it. I mean, I often get this question, well, how does it work, or how do we know that, or where's the science? Well, there's a tremendous amount of science here, and so this is a great reference for that. But one of the things that they found was that the ATP, obviously we went back and re-examined some of Robersch's early work from the 1978, 1979, and then tried to correlate the total amount of relative light units. That's when we're using bioluminescence. That's the the denominator that we use is the term is relative light units, which is then directly related to the amount of ATP, versus the amount of total bacteria in a sample, and found a correlation of Pearson R value of 0.854, which is a very strong correlation. 1.0 would be perfect, 0 would be no correlation, and minus 1.0 would be a perfect negative correlation. So anything from about 0 to 0.3 on a Pearson is a mild correlation. From 0.3 to about 0.7 is a moderate, and from 0.7 and above is a very strong correlation, and you don't see correlations like this very often in research. So we knew that the ATP-driven bioluminescence certainly would work in terms of us measuring total bacterial load. Then we got down into the samples and started looking at, well then, how does that relate to the total amount of oral streptococci? Does that correlate to the total streptococci that's in the plaque sample? And then does that also correlate to the mutant streptococci that are present in the sample? And would that correlate then to the patient's caries risk directly? And so that was the kind of the train of thought that was the research pathway that we went down, and found that we had strong correlation again to with a Pearson of 0.840 and the cariogenic streptococci in the mouth as well in those samples. And this actually won the Oregon Health Sciences University Research Award back in 2006, and they got a new microbiology department, research department out of that. And of course now we built a brand new dental school which will open here, I think in July of this year at OHSU. So it's some really good pioneering research here from OHSU, but again, we had that very high correlation to the total streptococci and also to the mutant streptococci. We came in at 0.796 as well. So we know that there's a strong correlation between the ATP and the levels of direct levels of mutant streptococci, which again, this was not an anticipated result, because you're talking about taking a generic factor in ATP, which is common to all living cells, the human host as well, and we're looking at generically at all the bacteria that are present, and to have that level correlate directly to the levels of mutant streptococci in the sample was not an expected result. But what that did for me was told me that we could use this quite effectively then to maybe apply this to a person's individual caries risk. So they also then looked at caries risk level against the ATP levels that were present as well. And you can see on this chart, you had patients that had low caries risk, normally had, in a very narrow window, but normally had, in this patient sample, had very low levels of ATP. The medium risk patients had a range there, kind of a moderate range from low to medium. And then the high-risk patients had generally high readings or higher readings, but there were also some low readings there as well. And that's one of the things that when you're looking at sensitivity and specificity, you're always going to have some false positives and false negatives in any test that we're using. Kind of the gold standard is 80% sensitivity combined with 80% specificity to get a combined of 160%, or 1.60. You'll see it expressed that way at times as well. And then this was a study that I did independently in my practice back in 2008. It was a randomized and it was double-blind, and I did a caries risk evaluation on the patient, and then I had a researcher actually just measure the ATP, and then we just plotted those 2 points against each other. And so what we found was that the data broke pretty well at about 1,500, and that's really where we got our the data to say, in terms of relative light units, if they're above 1,500, they have kind of a high ATP score, higher bacterial load, higher caries risk in general. If it's below 1,500, generally those patients are low caries risk. We're going to talk about, there are some variations, and we'll talk about that in a little bit. But what I found interesting is that my samples, of course I had a larger sample size. If you go back and look, my samples look not too unlike the samples that were done at OHSU, so I felt pretty confident in the results of our data. Now, one of the things that we know for I I think that was well established. I wanted to say that we know for a fact, but let's say that was very well established or very dependable in our scientific research. With this 6-year retrospective study that John Featherstone and Sophie Domagine did down at UCSF, they had 12,954 patients in this study over a span of 6 years. So, you know, that's a large patient pool. That's a large cohort. And so I feel pretty confident in their data. But they looked at and determined what were the caries risk in that population of dental school patients, and 15.5 were classified as low risk, 22 as moderate risk, and about 63% as high or extreme risk. The one thing that came out of that study that I thought really validated what we've been working on is that the #1 risk factor, when you look at it in terms of odds ratio, the #1 risk factor was patients reporting or you could visibly see plaque buildup on their teeth, and that had an odds ratio of 2.55. So that, in my mind, supported the fact that high plaque buildup, high bacterial load, which would result in a high reading of ATP, also put this person at a high risk for dental caries. So we worked on developing a meter and swab for dentistry directly to relate to dental caries. And of course, that's supported by the insurance code D0425, the caries susceptibility test. And so then these are some of the early papers that we wrote at OHSU. This was, in fact, the first paper had a strong positive correlation at 0.76, and we actually got better in terms of our sampling, and that's why we got higher results as we went down the road, as we learned and understood how to sample better and to get better results or more predictive results. And it had a positive correlation with caries risk, and this is a white paper we wrote back in 2006, again with Kurt Machida and Tom Meyer. This was Fazolat and sour wine. Another paper, again, looking at this, taking it a step farther, doing the research again, refining the sampling technique and looking at it, and that's where we came up with the much higher Pearson values for correlation to total plaque sample, oral streptococci, and then also mutant streptococci, and then by extension then also caries risk, and determines this could potentially then be a risk assessment tool. It would be something that we could maybe use to help aid us in determining a patient's caries risk. In this study also from OHSU, this was presented at the IDR back in 2008. They looked at plaque around orthodontic appliances and found very high correlated values at 0.895, 843, and 0.781. And so in terms of an orthodontic patient, if I were an orthodontist, I would be sampling every patient before I would put brackets on their teeth. I could probably predict which patients were more at risk for white spot lesions when you took the brackets off, based on where we were starting from. And certainly during treatment, I'd be sampling patients at least once or twice a year just to make sure that what those bacterial load looks like, because the white spot lesions, I think, are the greatest challenges for orthodontists today with patients, particularly when I talk to them and ask them that question. And I think that's the greatest challenge they have in practice in terms of with patients and satisfaction, et cetera. But so here's a simple way that you could test for where you're at with these patients, and rather than just telling them they need to brush and floss more, you actually have some objective data that you can use and help educate and use with the patient. But we know that in this study it related directly to also the number of mutant streptococci that the patients had. This was another orthodontic study that was done at OHSU, and this was published in the American Journal of Orthodontics. And again, here are the bioluminescence values statistically correlated again to total bacteria and oral total streptococci. And their conclusion in this study was that this could be a tool to use for immediate assessment of chairside, immediate assessment of oral hygiene and bacterial load during orthodontic treatment. And I would tell you that certainly this is a risk assessment tool that you could use chairside for immediate assessment for every patient. But certainly it has certainly would have an excellent role in orthodontics. I don't know if there's any orthodontists that are with us tonight. I know we have a large number of people on this webinar, but if I were an orthodontist, literally I would not practice without this. And then in about 2008, we began a clinical trial. Dr. Carrot Hallett, who was the head of pediatric dentistry at Griffith University at the time, took 2 high-risk school populations. The children were all developing like an average of 2 new cavities per child per year. And we actually used the study they did, use the treatment minutes was a double-blind randomized controlled trial. The kids used the treatment minutes just one day at school, and over the span of 3 years reduced their decay rate. That's all they did, by 73% in the test group. But early in the study, Carrot looked at, well, what type of biometrics do we have to use? And he tested ATP bioluminescence. He compared it to a couple of different commercial cultures that were available. He looked at 2 or 3 different types of plaque indices. So he went through all of these things, and his conclusion and early in the study was that nothing was predictive on the baseline caries indices of these kids except for the ATP level, and it was highly predictive. And he termed it biofilm activity rather than, relative light units or just ATP levels. He actually kind of came up with the term biofilm activity, and I think it's a very appropriate term. Basically you're measuring the activity level of what's going on in that biofilm. And this paper was done, Terry Donovan and a couple of students at University of North Carolina. This was presented at the IDR back in 2010. And they looked at patients, and they just compared directly. They did basically the same study that I did earlier that I shared with you. And they looked at these patients, just compared their ATP level, from the caries screen, to their caries risk, and did that correlate. And the conclusion was that it correlated well. In fact, it could be a useful chairside caries risk tool, although that it should be used in conjunction with other tools as well, so not a standalone. And I think as we go through some of the patient samples and some of the data tonight, hopefully that will make sense to you. And of course, I've always recommended that this is just one data point, and it's giving you a very accurate measurement of the ATP that's present. The question is, how do you interpret that data, and what decisions do we make from it? But occasionally a practice or a dentist would relate to me, well, I got this unexpected reading and so it doesn't work, or I don't know what to do with that. And it's like, throw the baby out with the bathwater. And the reality is it works extremely well. It's giving you a very accurate number of how much ATP was present. The question is, now it's for us to try and determine is what do we do with that data? How do we interpret that, and how do we use it? But I think it's a great adjunct. I wouldn't practice without it, and so I have it along with my other caries risk assessment tool, primarily, which is my caries risk assessment form, which we've reviewed, late last fall in our webinar series. And so yet another study that was done, and this was published in the Journal of Pediatric Dentistry. Carriage paper was published in the International Journal of Pediatric Dentistry. This one was published Fazalot in 2010. And again, they suggested that based on a study they did with children at OHSU, that the caries screen, or ATP bioluminescence, is a potential risk assessment tool for children as well. So we use it in children, we use it in adults also. One other thing that we've started to see over the last 4 or 5 years is there's been, I couldn't even tell you how many, there have been multiple research studies that have been done in dental schools at the U.S. In fact, I just had 2 abstracts sent to me this morning that I wasn't even aware of that have been done, just completed recently. But people are starting to use ATP bioluminescence, the caries screen meter, to test as the metric in the study. And so, they're using ATP bioluminescence. This was a study, this was just looking for live bacterial samples, but using ATP to test for bacteria in vitro studies on 9 different mouth washes. But we see study after study where people are starting to use the caries screen meter actually in the study as the metric. They're not studying ATP necessarily, but they're using that in our equipment as the metric to do their research with. So, I feel very comfortable telling you that I have a high degree of confidence in using ATP bioluminescence and using the caries screen meter with my patients. again, I just would tell you I wouldn't practice without it. And yet one more study that was done in orthodontic patients looking at a couple of different types of brackets, self-ligating appliances versus, elastics. And again, the same conclusion, the ATP can be used as a risk assessment tool. It very accurately measures the amount of total plaque or the bacterial load that's present. That was published in 2011. So there's been a lot of research, we have done, and we've done the lion's share of that. OHSU has done the lion's share independently as well. These have been research projects by a lot of graduate students at OHSU. So if you look at the amount of, there's a tremendous amount of research out there, but there's research going on. Minnesota, I think there were 17 studies going on the last time I checked at different dental schools involving ATP around the country. One of the studies that we did in 2011 through 2013, we did a multi-site study using a caries risk assessment form, and I wanted to know, I basically looked at Featherstone and the Damaging study, the 6-year study with 12,000 patients, looking at what does that population look like in the dental school. I wanted to know, well, how does that look in a private practice? And I've shared this with you a time or two before, but again, it was a 6 multi-site study. And really, we're talking about here, you can see the medications, the dietary issues between drinking and snacking, the dry mouth that patients self-reported on our form. But primarily what we're talking about tonight with the ATP bioluminescence, I'm really trying to get a clear picture of the plaque issue. And really as that relates to, do they have cavities, and trying to correlate. Of course, we're always trying to, I think we make the mistake of wanting to say, oh, you have a high ATP score, and that means you have a lot of cavities, and that may or may not be true. What we know is that you have a high ATP, you have either high bacterial load or you've got a high biofilm activity. You absolutely have one of those two things going on, both of which increase your risk for dental caries. So if you go back and start and look at this, and how do we interpret that data? Basically, from our study and the continued research we've done, 1,500 relative light units is really a good breaking point for the data. It breaks well there. It's a good cutoff point, from high biofilm activity versus low. So above that, you've got high biofilm activity. Below that, you've got low biofilm activity based on, a number of studies and data. But this really, in my mind, this is not really just an above and a below the line. You really got a grid here, or quadrants, because you have patients in both groups above and below the line that have no cavities, and you have patients above and below the line that also have cavities. And so you have the patient that has low biofilm activity and has no lesions in that quadrant in the lower left hand. Well, we kind of anticipate and expect that, and that makes sense to us. And so when we see that, we go, yep, the data fits, I've got it. You're low risk. And on the conversely, when you have a patient that has high biofilm activity and they have frank cavitations, you can see, they're high or extreme risk. And so it's like those two things make sense to me, and it's like, yep, those were expected results. And so that works really well. Where we get into an issue, I think confusion for most of us, is when we see the patient that has cavities, yet they have a low biofilm score or low biofilm activity, and yet they've got cavities. And you look at that and go, well, I was really expecting to see a high biofilm activity. And so what does that mean? And we're going to talk about this. And at the same time, you have patients that also have high biofilm activity that maybe don't have any cavities. And so what does that mean, and where do we go with that data? Because you're going to see a few of those. There still means they're high risk. If you have cavities, you're high risk. If you have high biofilm activity, high bacterial load, we know that you're at high risk. So it's like, so where do we go in terms of interpreting that data, and how do we use ATP bioluminescence? Well, here's primarily how I use it. I want a baseline. I want to know where we're at with bacterial load. I'm not depending upon this to tell me whether or not they're high risk or low risk, or or should they have cavities or not have cavities. What I want to know is, do we have high bacterial load or high biofilm activity? If we do, I'm going to use antimicrobial therapy as one of my strategies in treatment. If I have low bacterial activity or biofilm activity, I don't see the point in putting somebody on antimicrobial therapy. They don't have a bacterial problem. Yes, they could have cavities and be high risk for decay, but it may be because of a dietary issue. It may be because they don't have any saliva. It may be because of a lot of reasons other than bacterial load. And so if you don't have a high biofilm activity or high bacterial load on a patient, you're not going to get any benefit from putting them on antimicrobial therapy. And so if you don't have some kind of metric that you can look at and make that decision from, then you automatically put anybody that has cavities, they automatically get put on an antimicrobial therapy. And today, of course, I would be using sodium hypochlorite and fluoride. The gold standard had been, chlorhexidine and a 0.05% fluoride rinse. So it's like we would just blanket put everybody on that therapy, but for some people it seemed to help, and I had other patients in my practice that didn't seem to help at all. Well, that wasn't their issue. And so we really need to target our therapies, and this is one way using bioluminescence to do that. The other thing that's really, I think, really helpful with, and I don't have a slide on this in the presentation tonight, but one of the things that I really use is ATP for as well as an educational tool and a motivational tool for the patient. You have somebody that's high risk or type 5 extreme risk, here's a great opportunity to motivate them to get started on treatment, maybe to get actively into the restorative care as well, and help them, motivate them to get them started, get them in your schedule, get them seeing you, because the one thing that we know from the Featherstone study is that if they do nothing, they have an 88% chance they're going to have an additional cavity next year and another cavity the year after that and the year after that, and it's like you can't keep up with them, right? So it's like you really, this gives us an opportunity to really help motivate the patient and get them to schedule and follow through with their care, both their therapeutic or care and also restorative care as well. And the one last thing I would share with you is that it gives us, ATP bioluminescence gives us an opportunity then to measure outcome. Like, how do you know you're done? How do you know that it's safe in this patient now to start putting in the $40,000 worth of expensive restorative, your best cosmetic dentistry? Where do you know that you can tell the patient that it's like, you're healthy, we're in great shape. If you want to go ahead and do this, let's proceed with that part of the treatment now. If you don't have some metric, then your metric is, are they getting another cavity or not? And I've had enough patients develop a cavity around one of my expensive restorations. I don't need that to happen to me ever again, because it's always my fault when that happens. But the reality is, we can predict and we can get better at how we treat patients and prevent that kind of situation now. So it's really a matter of, you can measure your outcome. You have using it as a biometric, you have a surrogate endpoint. So it's like, yep, now I can measure this and know that you're healthy, you're stable. And again, that's also a very important educational piece or a confidence building piece for the patient as well. So we started, earlier with this pattern recognition, and, in our study, 51% of the patients had high bacterial challenge. So more than half the patients in these 6 practices measured with a high biofilm activity load when we just tested them, and we test everybody. So I want to give you a few patient examples. Let's talk about that, and let's kind of talk about how do we interpret this data and how do you apply it to your patients. So I've got 2 female patients here. They're pretty close in age. They are both high caries risk. Now, I think you can appreciate that the patient on the left has a different suspect than the patient on the right. And so the question becomes, how do we determine, we look at our caries risk assessment form, how do we treat these 2 patients? They both are developing new cavities. They're both high risk. How do we solve this to help these patients? Well, in the past, this is how I was trained in dental school, and I would just call this intuitive medicine. Basically, you've got cavities. We're going to use the drill and fill, and you need to brush and floss. We're going to tell every patient, drill, fill, brush, and floss. The patient on the left, that's going to be really helpful information to, The patient on the right already brushes and flosses twice a day. This person's teeth are as clean as a really passionate hygienist, right? To tell this person to brush and floss, that's not going to add any additional knowledge or benefit to what they're already doing. You know, in empirical medicine, then we started to look at this and go, well, there's a disease here, and now we're starting to look at studies, and things become more probabilistic, and I can quote data that if I put you on like chlorhexidine rinse, it's going to reduce your decay rate by 24%, and I do that to both patients. Well, again, if you look at this, the patient on the left is probably going to benefit from that antimicrobial therapy. The patient on the right, quite frankly, you're wasting your time with with any antimicrobial therapy. But in the day, we were using chlorhexidine and fluoride rinse, and we gave it to everybody. If you were high risk, everybody got it. Well, it kind of helped some patients, and it kind of didn't help others because we weren't targeting the therapy, and that's really what Canberra is really about. I had a dentist last week. Dentist I've known most of my life, actually, asked me, well, Kim, what do I tell a patient? What do I tell them that causes decay? And it used to be a pretty simple answer, and it's not that. And there is no one answer anymore. And I said to this dentist, it really depends upon what's causing the question becomes what's causing the decay in that patient, because I can't come up with a single answer to tell these patients, both of these two patients, what's causing your cavities, because it's not the same thing that's causing their cavities. So it's different for every person. At the end of the day, yes, it's about you have prolonged periods of low pH in your mouth, which is causing the loss of the mineral out of your tooth, and then the bacteria be able to invade the tooth and actually start feeding on the tooth itself. But it's like, the things that are causing that situation or putting you at risk for these two patients aren't one and the same. So we need to target then our strategies specifically to those risks. So if we go back to just the usual suspects, kind of in a general sense, if you've got a patient that has a bacterial issue, you're going to use antimicrobial therapy perhaps and or behavioral coaching like home care and etc. If they've got a dietary issue, we typically need to talk to them, and again, this is where your educational and coaching piece comes in, limiting the amount of sweets that they eat or maybe limit their snacking. They may be snacking too frequently. If they've got a salivary issue, typically that's hyposalivation that's caused by the medications they're taking. We just want to make sure they keep their mouth wet during the day and that they're hydrated, and that they're neutralizing their mouth during the day and not using acidic things in it, like half of the bottled waters have a pH of 4.0. So if you want to, I tell patients to drink water, well, make sure that you're drinking water that either has neutral or better pH, or drink tap water, and you're going to be safe. But know what the pH of your water is. And if you're using oral health care products, you might want to look at the pH of those products and think about neutralizing, because saliva, the role of saliva is alkaline. It neutralizes the mouth, and that's what creates the remineralization, creates the equilibrium. You take the saliva out of the equation. If we want to keep the person healthy and balanced, we have to put something back in its place, which is going to help neutralize that. That's the whole concept behind Carifree. And then if it's a genetic thing, I can't measure that right at the moment, but if I run out of every other suspect and I don't come up with anything else, I'm going to suspect that it may be a genetic issue. And certainly, Schaefer and Feingold published papers in the last 2 years that started to describe geographic patterns of decay in the mouth that are directly tied to a genetic trait or inheritance pattern. So it's like we might be able to look at something and go, oh, I think this, you've got a pattern of decay here that really fits the research in terms of this may be a genetic issue. And all I can do then, again, is educate the patient to reduce or just minimize the amount of acidic episodes they have during the day and just try and neutralize and support wellness for them. So let's look at these patients in detail. The first patient here is, which I think we're all going to feel comfortable with, if this patient is high risk for dental caries, a 38-year-old female, infrequently sees the dentist, has some anxiety with that, not taking any medications that are going to affect her saliva, blood pressure, pulse is a little high, blood pressure is within normal range. You look at some of the radiographs here, and obviously we've got to start with some extractions. she's got some serious decay issues, some hygiene issues. There's tartar. There's all kinds of things going on in her mouth. We look at the risk assessment form, and it's like, she drinks things other than milk or water more than twice a day. She notices the plaque buildup on her teeth. You start at the top. Yes, she's interested in a screening. Yes, she wants to know about it. And, yeah, she's thinking she'd be able to change her behavior if that was required. Disease indicators, yes, yes, yes. She has all 4. They're all a concern to me. The ATP score, she pegged the meter at 9999. This patient is a type 5. In my mind, she's high extreme risk for dental caries. If she does nothing, I know she'll have an 88% chance of having a new cavity every year from here on until she runs out of teeth. So this is somebody that's, I would also use the ATP both as a baseline for her, something that we can then go back as a surrogate endpoint to know if we're making progress, but also as something to help motivate her with as well and get her started immediately. There's a sense of urgency here on this patient in terms of trying to get this corrected. So the risk factors and concern, disease indicators, biofilm challenge is a concern. The usual suspects are bacteria. She has high bacterial load and or high biofilm activity. I think, the plaque buildup on her teeth is evidence of the bacterial load as well. And then she has some dietary issues as we did further questioning, going through. That's interesting. Tell me more about that. Tell me what you drink during the day. And, part of the coaching language that I continue to try and weave into these presentations, instead of asking what do you drink, and this is not a cross-examination, tell me what you drink during the day. Tell me more about that. What I found is, and we're going to talk about some of the coaching language here specifically with this patient, but, here's a patient who's drinking Mountain Dew, like, 6 to 12 Mountain Dews a day, and she had poor oral hygiene. That's a recipe for disaster. So in terms of what are we going to do for this patient, well, we've got to do the reparative work, right? I need to get my fingers in the dike. Immediately I want to get all the decay out of her mouth and get either composite restorations in and or glass ionomers in situations that I'm going to go back and put crowns on or what have you. We did extractions. We're going to use fluoride. We're going to remineralize as much as we can. Therapeutically, yeah, this person's going on an antimicrobial agent immediately. In this case, it would be the Carifree treatment rinse. And behavioral, we need to start working with, we got to talk about how to brush and floss. And then recare, I'm going to see this patient every month for probably 6 months, and then I'm going to see her every 3 months for probably a few years until I'm confident that we've got everything under control and she's stable. So we get into the coaching conversation, and we've changed. This is from Ferocia Knight at the Brock Institute in Portland. She's my wellness coach, and Ferocia has been working with me in the last year trying to develop a coaching language, a system that just integrates into what we're already doing. So instead of spending an extra 30 minutes trying to coach a patient, we actually weave the language into the conversations that we're already having. And she came up with these 5 points, envisioning the patient, educating them, enrolling, empowering, engaging, and how we talk to patients, the language that we use really affects our outcome. So some of the sample phrases here that I use, envisioning, you want to see the person as a whole, capable, competent person that has a disease. And I don't want to be accusatory. I don't want to shame them. I don't want to do any of that. I want to be curious. I want to find out what's driving their disease so that I can, educate them about that, and I can help coach them to make whatever changes are necessary so they can be healthy if that's what their goal is. And when we go to educate, instead of telling a patient, you have this, you have that, which again, brings out the kind of the guilt thing, you have 5 cavities, what I found is a cavity on this tooth. What I found is, that language is non-accusatory as well. And then when we go to enroll the patient to work with us, it's like, what do you want to do? What do you want to focus on? And focus is the key word here. What do you want to focus on? What do you want? And how is that going to benefit you? If you can get them to tie an emotion on how that's going to benefit them in their life, a greater chance they're going to be successful doing whatever they're trying to accomplish. And it's really important that we empower them. I know you can do this. I totally see you being capable of accomplishing that. That's doable. I'm in your corner. I know you can accomplish that. And, having that confidence, somebody else's confidence in us, may inspire us to pick it up and do it in spite of the fact that we don't have confidence ourselves. I know that I've experienced that in my own life. And I think that that's, somebody that says to you, yeah, I know you can do that. Wow, you would be great at that, may kind of influence us to be better at it and to accomplish it. And then engage them in the process, like how, where do you want to start? What would you do first? What is the first step going to be? Asking them, like for this patient, obviously we've got a couple of things that we need to do. We need to work on behavioral issues with brushing and flossing, and we need to make a dietary change. Now, she needs to learn how to brush better, she needs to get better at flossing, and she needs to eliminate Mountain Dew out of her diet. One thing we know about our wellness coaching is that human beings don't make 3 good changes successfully all at the same time. In fact, if you want to be successful, it needs to be one thing. So typically in the past, I would dictate. I would say, okay, we're going to work on brushing. That's number one. We got to do that first. Or I would say, you've got to give up Mountain Dew. You have to do that first. Well, over the next couple of years, this patient knows that if they want to stop having cavities and have a healthy mouth, those are 3 things they're going to need to change in their life. The best thing to do is ask them, which one do you want to do? Which one is most important to you? Where do you want to start? Because at the end of the day, do I really care? Do I care if she starts with the Mountain Dew or the toothbrush? Do I really care knowing that she knows over the next couple of years, and change is not linear and it takes time. So, it's 1 step forward, 2 steps forward, 1 step back kind of thing. It takes time. So it's like I'm going to need to be patient with her. I've got to get in and do some restorative stuff and extractions and things right away. But do I really care if she starts with a brush or Mountain Dew? No, I don't care. As long as she starts with something, and I want her to be successful at that, so the next change that she decides to do is going to be that much easier for her to be successful at. In this case, she wanted to give up Mountain Dew. That's where I want to start. I want to give up Mountain Dew. And I'm like, how do you plan to do that? Like, what's your plan? Tell me, how are you going to tomorrow, how are you going to get yourself off of Mountain Dew? I'm not going to tell them how to do that. This patient needs to come up with that plan on their own. And she laid out a plan. Here's how I'm going to do this. I'm going to limit myself to, 2 Mountain Dews a day, for the next week, and I'm going to start drinking some iced tea without sugar in it, and then I'm going to cut down to 1 Mountain Dew a day, and then I'm going to cut down to, 2 iced teas, and then I'm going to replace those with water, and that's when we got into the conversation of, what kind of water are you planning on drinking, to make sure that they know that, and, that's how you start, and that's how they become successful. So 2 years later, this patient looks like this. Now, I got to tell you, do we still have work to do? Yes, we do. But she's stable. She hasn't had a cavity in 2 years. And this is the cleanest that, this is the best that she's done with her brushing. And we haven't started the flossing yet. But this is a celebration. I mean, to go from that, where she was, to here, and know that she understands and she's trying really hard, and she's doing making a good effort, and she's made some tremendous improvement. I'm really proud of this patient, and so those are the moments that we celebrate. I pat them on the back. You've done a great job. Keep it up. You've got a new habit. We're working toward a better health all the time. So that's kind of the language that we'd use. So obviously that patient would benefit from antimicrobial therapy. Now let's look at the second patient. She's 36 years old. She takes Synthroid. She brushes and flosses twice a day. Do you believe her? Yes, I believe that. Does she need to brush and floss better? I don't know how she could brush and floss better. Looks like she's pretty well got that down. Blood pressure and pulse are normal. You look at her radiographs. Now, this patient came to me, and this patient has had a lot of sandwich restorations posteriorly. I used to do these quite frequently. I haven't for years, but the one thing we know about glass ionomer is that it does dissolve. And in an acidic mouth, so the first thing that I look at these x-rays and I see is this patient has a very acidic mouth. She's dissolving the glass ionomer out of these restorations. When you see that, I can assure you that this person has an acidic environment. Now, is that from erosion? No. this is a situation that in my mind is being caused because she doesn't have saliva. So I didn't see any saliva in the picture, so my usual suspect right out of the gate on this patient is this person has a salivary problem, and it's confirmed immediately on the radiographs. I know that without saliva, that's what happens to these glass ionomer restorations. So we look at her risk assessment form. Well, she takes medications. One, takes Synthroid. We know that. She's very motivated. You know, yes, yes, yes on all of the behavioral questions at this top. And we get down here. She has radiographic lesions. She has had cavities. She's been developing about 2 new cavities per year. Her dentist has been telling her she needs to brush and floss better. She was pretty insulted by that. I don't blame her. You know, and we look at her caries screen. It was a little bit high. It's at 2,600 versus, you know, we broke the data at 1,500. So she's yes, yes, yes. She profiles out as a high extreme risk patient, and that fits all of the data that we know about her. Looking in closer detail at her, you know, she's got a dry mouth. Hyposalivation is a better term for us to use than xerostomia, at least in this patient at this time. So her risk factors are concerned, disease indicators, high biofilm challenge, and usual suspect in my mind is saliva. She's got hyposalivation. Well, what's causing that? She's 36 years old. You know, so I kept asking the patient, you know, so tell me more about that. You're taking Synthroid. Synthroid wouldn't be causing that, but I suspect, you know, that there's a lot of medications do. Is there any other medication that you're taking that you forgot to mention or that you didn't think was, you know, important? You know, just, you know, anything else, tell me more about that. Well, it turned out that she also happens to be taking Wellbutrin. She'd suffered, had been, you know, it's a mood-elevating drug. She'd had a little depression. She'd gone through a divorce, and so she'd been taking this drug, you know, for the last few years, and, you know, and I have to tell you, Wellbutrin, if you see patients taking this, they're going to have a very dry mouth, and you're going to see a situation kind of very much like this patient. She said, oh, you know, you're talking about this dry mouth. You know, my mom was just recently diagnosed with Sjogren's syndrome. Well, if there's one thing we know, that's a big red flag. If there's one thing we know about that disease, it's an autoimmune disease of the salivary glands, most commonly in women. It's hereditary, and typically we see that in women diagnosed in their 40s. So, you know, here's a woman that's 36 years old and has a hereditary family history of Sjogren's syndrome. You know, that's a big red flag for me. So we talked about what's causing your disease and how do you go about that. So again, when we look at then, you know, reparative, she needs to have those restorations replaced. I wouldn't put glass ionomer back, sandwich restorations back in a mouth like this. I would go straight to composite or, you know, porcelain inlays if you wanted to. Therapeutic, now here comes the big question. Do you put this person on antimicrobial therapy or not? You know, that's the question. You know, she had and I wouldn't tell you, if you decided, if your answer was yes, I wouldn't disagree with you, and if your answer was no, I wouldn't disagree with you. Now, I hope that confuses you a little bit, but let's talk about it here. She has slightly elevated, you know, biofilm activity, but I know that that's not her problem. Like, she does not have a bacterial issue here. That's not driving this. The lack of saliva is driving it. So in my mind, I really don't think, I don't see a real benefit in her mouth for putting her on antimicrobial therapy. Now, if her score was like 7,000, yeah, that's a different ballgame. Yeah, I would probably do it then. But at, you know, 2,600, it's a little elevated. I'm going to go ahead and just start talking about remineralization and neutralizing and hydrating her mouth so that she understands what's causing that and go from there. So again, we go through our open-ended questions, the same ones as before. We weave that language into our conversation with the patient. And then we go through, you know, your reparative, restorative, etc. I'm going to give this patient to you as well. Another female, 48 years old. She happens to take Synthroid. Blood pressure is, you know, is within normal range. Pulse is normal. You're looking at these x-rays and going, okay, I think we're all comfortable. If I said this patient is high risk for dental caries, I think we'd all be okay with that. She came to me and basically wanted to have dentures made. That was her, you know, my teeth are bad. I think it's time for me to have dentures. So, you know, she wanted the test. She's maybe interested in discussing saving her teeth, but she's really down the mindset of, I think I'm headed for a set of dentures here. When we look at her risk assessment form here, the thing that stands out to me here is she's drinking iced tea with sugar all day long. She's drinking sweet tea all day. That's all she drinks, and she drinks it throughout the entire day. Now, interestingly enough, we get down to her caries screen score, and it was low. It was 658. So you kind of go, huh, well, gosh, she had a lot of bacteria, a lot of cavities, but she's got a low caries screen score. Well, it's not if you go back and look at the photographs of her teeth real quick, she doesn't have a lot of bacterial load. She doesn't have a lot of fur on those teeth. They're fairly clean. She just has a lot of decay. My conclusion is this is a type 4 patient in our caries risk assessment form. She doesn't have a bacterial issue. What she has is a dietary issue. She's strictly eating, consuming too much simple sugar, and it doesn't take very much bacteria to turn that in and create decay in your mouth. So would this person benefit from antimicrobial therapy? And I would tell you, no. I don't see the point in putting a person who has decay but has a low biofilm activity score, low caries screen score. This is not a person I'm going to put on. So I've given you 3 high-risk patients here tonight. One would benefit from it. One, you may or may not put them on it. That's your call. And you'll get experience with that, and as you do more and more, see more patients. And then here's one where the answer is no. She's got a lot of cavities, but this isn't a bacterial issue. This is a dietary issue. So this is type 4. It's diet, iced tea with sugar. And so basically for this person, that whole coaching conversation was, I think I can help you save your teeth if that's something that you would value or something that you would want. I don't see you having to have a set of dentures. So it's like if you wanted to save your teeth, I can help you do that. I can teach you how to do that, how to get healthy and how to stop having cavities. And of course, the number one thing she's got to do is stop drinking iced tea with sugar. And so, you go through that whole coaching conversation again for a patient like this, and her conclusion was, I'm going to switch to, iced tea with an artificial sweetener, like NutraSweet, and then I'm going to stop that. I'm going to learn how to drink my iced tea black, and then I'm going to learn how to drink water, and like maybe have one iced tea a day and in the morning, and then try to learn to drink more water during the day. And again, that water conversation comes out. Make sure you're drinking water that has a neutral or higher pH. So again, it's the same coaching questions that you go through, but I kind of wanted to give you a range of these patients all were high risk for dental caries. They all had a different suspect causing their disease, and one of them definitely would benefit from antimicrobial therapy, one may or may not, and one would not. So that you kind of learn to look at patients and go, this is how I use this in my practice. And it makes sense to me. So are you ready? I guess that's the question I've got for you. I hope I validated in your mind with the amount of science that we have that this definitely accurately measures the amount of bacterial load in a patient's mouth and or biofilm activity level. What we do with that data, how we interpret it, and how we use it to prescribe our therapies with the patient, I think that then really falls onto the caries risk assessment form and allows us to target our strategies to be more successful for these patients. So I want to thank you all for being with us tonight. We're right at an hour. And also, I know that the team here at Carifree, if anybody is interested, if this is the first time you've signed into one of our webinars, or you're just starting to learn about caries risk assessment or Canberra, and you want to, or Carifree in particular, and you'd like a copy of the book Balance and some of the products to actually try, this is certainly available. So contact us, and we'll make sure that we get a breakout box to you. So Janelle, that's my presentation on ATP bioluminescence. Do we have any exciting questions from the audience tonight?
Yeah. Thank you, Dr. Kutsch. Like you said, we have a lot of people joining us tonight, a lot of really great questions. I think we have time for a few. The first one is, how would you explain a low reading to a patient who has existing or progressing carious lesions?
Okay, so that literally was the last patient, that I just shared with everybody. And I hope I answered that question in that presentation. But basically how I'd explain that to the patient is you're high risk for decay, but you have a low bacterial score. So what's causing your disease isn't an abundance of these bacteria. You don't have an overwhelming amount of these bacteria in your mouth. What you've got going on is something else. And whatever that case happens to be for that patient, in this patient's exam, it happens to be her diet. And we were able to identify that and help her understand, help coach her through her deciding on what changes to make. And by the way, she decided to save her teeth, and she's in active treatment with me right at the moment. It's been kind of an exciting case because she's really a really nice lady, and it's exciting. Anyway, so really it's just a matter of being able to explain to the patient what is causing their disease, and it's not what we've eliminated or ruled out is the fact that it's not a bacterial issue. So I'm not going to necessarily be putting them on an antimicrobial agent.
Great, thank you.
Great question.
Next question is, how do I convince a patient with a high biofilm rating but who has never had a cavity the benefits of treating their active infection?
That's another really good question, and let me answer it this way first, and then I'll talk about it specifically. But how would I convince a patient who has high blood pressure but's never had a stroke yet to take take a medication and think about treating their blood pressure? It's really the same kind of thought process. I see quite a few patients that have high readings. They don't seem to have any decay. Occasionally they'll have a cavity, maybe. Like every 5 or 10 years, they'll come in and surprise you with a new cavity. But for the most part, if they don't have visible plaque on their teeth, and so you're not suspecting that they have a high bacterial load, like their teeth are pretty clean, and this is typically when I see it. They have pretty clean teeth, but they've got a lot of activity going on there. They've probably got a lot of host resistance to the disease, so it's not expressing itself in terms of cavities. But if there were any changes in the mouth, so that, do they need to go through antimicrobial treatment? Probably not. But let's say they're 45 years old and that's the way they look and they haven't had a cavity for 25 years, great. Age 55, they develop hypertension or they develop an allergy. They start taking medication that dries their mouth out. And now within a very short window of time, like 6 months, you've got a patient that's a recipe for disaster, and at least you know about it ahead of time. The patient's aware of it, and it might be somebody that you want to have those conversations with. If you ever start taking medication, if something changes in your medical history or something, I really need to know, because it could lead to a situation where you develop a lot of cavities in a very short period of time. And I've seen that 2 times in my practice where it was devastating to the patient. Within 9 months' time, we were extracting teeth. And so that's, if I could prevent that situation, certainly that's something that I would look at. So it's really just the fact that they're in increased risk. If they want to reduce their risk, antimicrobial treatment would benefit them. But, as long as they're not developing cavities and they're not interested in the treatment, I'm okay with that. But I just need to know that if anything changes that increases their risk, that I'm aware of that, because, I don't want to see them come in and with severe decay.
Great. We have another question here. It seems to me that a large proportion of my patients screen high. Is this the case with the general population? If so, why?
Okay, so that's because because most people aren't real effective at their brushing and flossing, and maybe let's leave it at that. But I would ask you this question: are you screening everybody? Because one of the things that I know that practices, dentists and hygienists that start using ATP, they typically start using it on patients that we know are high risk. And so more often than not, you're going to get those high readings on those patients. And then it's pretty soon you're, oh boy, everybody's kind of reading high here. If you screen everybody in your practice, and this is from the sixth practice multi-site study, we found that 51% were above 1,500 and 49% were below. So the answer is yes. Slightly more than half of the patients are going to have an elevated reading. But if you're seeing a significantly higher number than that, you're maybe not screening. I would probably assume you're not screening everybody. And if you're kind of targeting patients that you think are high risk, or you see have decay, or you see have plaque on their teeth, you're always going to get a high reading in a situation like that. So it's just slightly more than half. So you should expect to see that half your patients should have a high score.
Great. We just have another minute or so here. One last question. I've had a few patients that have gone through 2 or 3 rounds of treatment with their Carifree kits, and after 9 months, the reading is still high. What contributes to this?
Okay, that's a great question. Several things could be contributing to it, and I don't know the exact answer for that patient. It could be a compliance issue. You know, maybe they haven't really been using the rinse. I mean, and that's always a frank and honest, you know, question to ask a patient. It could be that, and more likely, I'm going to assume that your patient is complying. More likely, it's something that there's something still going on that you haven't identified. And it's like if you're looking in their mouth and they started with this high bacterial risk, like if you look at the first patient, I could have put her through three month rounds of treatment rinse and, you know, antimicrobial therapy, and one of the issues that she had was bacteria, and it's going to reduce that. But one of the other issues that she's got is a dietary issue, and if we haven't resolved that issue in that period of time, she may still score fairly high because of the amount of sugar that she's putting in her mouth every day. We've reduced the total bacterial load, but the activity of the bacteria that are still present is high because of the amount of sugar that she's taking in.
Great.
I hope that makes sense. I know that may seem a little confusing, but I hope that makes sense from the standpoint if you've still got somebody that's reading high, there's some other suspect that you haven't addressed or maybe haven't identified yet. And that's happened to me as well. You know, I have the one patient that she turned out she was taking several medications that I didn't know. She didn't kind of consider them to be medications, and they were very much affecting the dryness in her mouth. So it's either something is still going on that hasn't been resolved, or there may be something going on that you're not even aware of yet. But and if you're still seeing a high bacterial load, then it may be a patient compliance issue. So that's kind of how I would address that. I hope that makes sense. Great questions, by the way, Janelle. What a great
and thank you, Dr. Kutsch. And do you have anything else to add before we wrap up the webinar for this evening?
No, I just want to really tell you how much I would tell everybody how much I deeply, honestly appreciate you spending an hour with me on these webinars, and because everybody's time is valuable, and so that you've taken the amount of time and you have the passion, certainly that I share for dental caries. I want you to know that I really appreciate that. I don't take that lightly, and I hope that what I've shared with you tonight in terms of ATP helps answer a lot of the questions that you have, or helps make you more effective in terms of your outcomes as you're dealing with your patients, understanding and interpreting the data and learning how to work with it to get better outcomes. That's what it's all about. So I just want to thank you all for being with us tonight. And thank you, Janelle.
Yes, thank you, Dr. Kutsch, and thank you to everybody for all your great questions. Again, any questions that weren't answered by Dr. Kutsch will be answered via email within the next few days. And an email will be sent out tomorrow with a link to the recording for anybody who wants to share this webinar with their staff. And please feel free to contact us with any questions. Again, as Dr. Kutsch said, we do offer one-on-one webinars, and we'd be happy to schedule one for your team. So thanks again, everyone, and have a great night.
Good night.